Medurstand. Understanding medicine.
I'm Professor Aziz-ur-Rehman, and this is the second of the series of lectures on metabolic complications of diabetes. In the first lecture, we discussed pathophysiology of DKA, diabetic ketoacidosis. And if you landed up here directly, I suggest that you go back and watch that video and then you come to this video, because that way you will understand the treatment of diabetic ketoacidosis much better. Now, management is based on one basic principle, that is replace what is deficient. In the last lecture, we identified some of the things which are deficient, and I think we will identify them again today, and then we will develop a strategy how to replace them, and hopefully by that the patient will recover. First of all, there is deficiency of insulin. That is the fundamental abnormality in diabetes. Because in type 1, there is near absence of insulin. That is why DKA typically develop in type 1 diabetes. But in some cases, it may develop in type 2 diabetes also. So whatever scenario may be, whether it is type 1 or type 2, in DKA, we have to replace insulin. We can't just trust on any oral agent. Then, because we identified that typically patient is deficient by 6 or 7 liters because of osmotic diuresis, so we will have to replace fluids. There are various types of fluids, but standard is normal saline. So we'll replace with saline, approximately 6 or 7 liters. Then patient is depleted of some essential electrolytes. Patient is depleted of sodium. Patient is depleted of potassium. But I have listed only potassium here because when we replace fluids, we typically replace with normal saline. So sodium will be replaced in the form of normal saline, but we will have to add potassium to normal saline to replace potassium. So we will discuss how do we do that. Then is bicarb. Bicarb deficiency is also there, but mostly it is not required to replace bicarb in milder cases, because once the basic abnormality is corrected and the bicarb, they become normalized, they become normal on their own. As the acidosis is reversed, it becomes normal on its own. But in some cases, and I'll show you which cases, we will have to use bicarb also. So let's see how we replace all these four components. Insulin therapy, there are some very detailed protocols. You could replace according to the weight of the patient, or you could also use according to the response. I think I have picked up this one, which I normally practice. Very simple and doable. This approach does not require too many resources, and it works in actually in majority. So first of all, in any serious patient, the first basic principle of the treatment is to establish an IV line, because you have to draw samples for laboratory tests, and you also have give all vital medicines through IV line, and in this case we have to give fluid. I think out of four, the most essential part of the treatment is replacement of fluid. So we can start with the regular insulin, regular human insulin, or the rapid acting insulin analogs can also be used. So regular insulin is good enough because we are giving it intravenously, so the action would be quick. Regular insulin, when given subcutaneously, the action starts late, but since it is going to be injected intravenously, the action will be straight, I mean very prompt. And I think the bolus dose of 20 units would be adequate. Although there are some protocols, they say that it should be like 10 units or maybe 6 units, but I believe that is too low. And previously, we used to use very high doses of insulin because we thought that it is the hyperglycemia which is the culprit. So we used to use 50 units also as a bolus, but these days I think I would say 20 units is very good starting dose. So 20 international units of regular insulin injected intravenously straight away. Then you set up an IV infusion. If you have infusion pumps, great. Otherwise, you just make an IV infusion and mix regular insulin in a normal saline and give it as infusion. Or you can give 10 units of insulin every hour as IV bolus. So that is also acceptable. So, of course, we will see how patient's glucose is coming down. If with that dosage I told you 20 bolus and then 10 units hourly, if glucose is not coming down satisfactorily, then you could upscale. We could increase the dosage from 10 to maybe 15 or even further. Or if the glucose is coming down too fast, we can reduce the dosage. So whatever dosage plan you use, it will have to be adjusted according to the response of glucose in an individual. Now the second part is the fluid replacement. Now again, I have made a very simple regimen which will be easy to carry out. In the first hour, the first hour after receiving the patient, you can infuse 1 liter of normal saline. So that you will have to do it fast because you will have to, I think, give it with the maximum speed with the usual infusion sets. You just open it and let it run and give almost 1 liter in first 1 hour. Since patient is very dehydrated, giving it fast would have no serious consequences. There is no risk of pulmonary edema or volume overload because patient is very deficient and patient is likely to be a young person with a relatively healthy heart, healthy kidneys. So don't be afraid of fluid overload. Give 1 liter as fast as you can. And then in the next 2 hours, you can give another liter of again normal saline. Now there has been debates which fluid will be an ideal. Somebody suggested hypotonic saline because this patient with DKA has got hyperosmolar state. So somebody argued that hypotonic saline could make a very good choice, but we have learned that that does not actually give any better result. In fact, they can cause brain edema. Then other types of fluids have also been proposed, but I think there is almost consensus that ideal fluid for replacement in DK is normal saline, and normal saline is also widely available, so there is no problem. In the first hour, give 1 liter, and the next 2 hours, give another liter. So 2 liters given, and then in the next 3 hours, give another liter. Okay, and then next 6 hours, give 1 more liter. So in first 12 hours, if you count these period, there's 12 hours. In the first 12 hours, you give 4 liters of normal saline. We don't give other fluids, just normal saline, because patient has lost his sodium and fluid. That means he needs replacement with normal saline. And you, of course, at the same time, you are monitoring blood glucose. Now, once blood glucose levels comes around 250 milligram per deciliter, now you know that 250 milligram is not normal, it is very high, but still at 250 milligram deciliter, we replace sodium saline with glucose. Now, if patient's dehydration is already corrected by this time, then you can stop normal saline and give 5% dextrose along with insulin. But if patient is still dehydrated, then you continue giving normal saline in a separate drip and add 5% dextrose. Why 5% dextrose is needed? The two reasons. One is that you do not want patient to go into hypoglycemia. 250 is fairly high, but still these patients, they can go into hypoglycemia without any warning. So I think one reason of giving glucose at this level is to prevent any hypoglycemia. The second purpose, which is no less important, that is to replenish body's stores of glucose. Body has been deprived of glucose metabolism because insulin was not there. Now that we have replaced insulin, now we need to replenish body's reserves and glucose is needed. So in fact, for several days, some additional carbohydrates are given so that patient improves better. This is now the third replacement, potassium replacement. Now, there are three situations. First of all, whenever you have to give intravenous potassium, you have to make sure that there is an kidney functions are adequate. If patient has got kidney shutdown, if there is anuria or oliguria, giving potassium intravenously can cause hyperkalemia, and hyperkalemia can have very serious consequences. So we must be sure that patient is passing good amount of urine and at least 50 milliliter per hour. So that is when we can give potassium intravenously. So there are three situations. First of all, let me pick up the commonest situation, the situation 1. Patient has potassium between 3.5 and 4.5 milliequivalents per liter. Now you can appreciate that this is normal potassium. Now you could wonder, if potassium is normal, why to then replace potassium? The reason is that this potassium is normal because as patient has been losing potassium from the extracellular compartment through urine, intracellular potassium has been coming out to maintain extracellular compartment potassium. So potassium is normal, but total body potassium is depleted. Now once insulin is replaced, once fluids are replaced, this extracellular potassium is going to go into the cells and resulting in hypokalemia. So to prevent that thing from happening, we will give potassium chloride even to somebody who has normal potassium. So this is the situation 1. I think idea is to keep between 4 and 5, and in these patients after first 2 infusions. After first 2 infusion, potassium is added and then it is given and maintained. So typically we add 2 ampules of potassium chloride in 100 ml of normal saline and infuse it. Situation number 2 is when potassium is above normal or upper side of the normal. Now this will be a relatively less common condition, but in this case you may not start potassium until patient's potassium comes to this range. So you just check potassium every 2 hours, and once it comes in this range, then you can start giving potassium from getting it further down. And then there's a third situation, very rare situation, but very important situation. Imagine somebody who had this DKA and his presenting potassium was less than 3.5. That means that he has depleted too much potassium and his intracellular reservoirs are also depleted, or maybe he was drinking simple plain water. So potassium is reduced. Now in this case, if we give insulin, what do you think? What can happen? If you give insulin to somebody who has hypokalemia, what is the effect of insulin on potassium? It will push the potassium into the cells. So that would result in more severe hypokalemia. And this hypokalemia is much more dangerous than hyperglycemia. So in this patient, I think we should hold insulin. Now important, if somebody's potassium is less than 3.5, then we should hold insulin, because insulin is going to push the excess cellular potassium into the cells, causing more severe critical hypokalemia, and then give 40 milliequivalents of potassium chloride per hour, like we did here. And then we keep monitoring. Once patient potassium has come to this range, 3.5 to 4.5, then we can restart insulin and we can continue potassium chloride also. So these are three situations. Let me emphasize again, replacing potassium is extremely important, despite the fact that at presentation you would see that the electrolyte tests that show the potassium is normal. Because once insulin is given, once fluids are replaced, the extracellular potassium is going to enter the cell. That is going to result in critical hypokalemia, and that could cause cardiac arrhythmia and may be responsible for death. So don't overlook this potassium. Normally we start giving it in the third drip, but if somebody has low potassium to begin with, insulin should be held, and first you replace potassium. Once potassium becomes the safe limit, only then give insulin. Very rarely, if somebody has hyperkalemia to begin with, maybe you can wait for third or fourth liter when we start adding potassium. Even these patients would need potassium replacement. The only person who may not need potassium is the person who has developed renal shutdown as a result of diabetic ketoacidosis. So you have to be very careful. So that is why first establish that there is sufficient urine output. Now, fourth component, our strategy is replace what is deficient, right? Now we are correcting acidosis by bicarbonate therapy. Now, if pH is 7 or above, then no bicarb therapy is required. Now, please note down that 7.1, 7.2, 7.3, they're all acidotic states. They're all less than normal. Normal pH is 7.4. But we do not replace with bicarb unless somebody's pH is 6.9 or less. Now, if somebody's pH is less than 6.9, we give just 100 millimole of bicarb in 500 milliliter of saline, and it is to be infused over 2 hours. This would only be sufficient to bring the pH to the safe level. This will not correct the acidosis completely, and that is not actually required. Not only it is not required, it could be actually counterproductive. I'll explain in one of the slides why routine bicarb is not recommended. This is correction of acidosis. Why not in every patient? Why not we give bicarb to everyone? Now this is, I'm going to explain. Number one is that acidosis reverses with insulin and fluids. So with this, of course, we are going to give insulin and fluids. If this is going to reverse acidosis, then separate treatment for acidosis is not necessary. This is the reason number one. But another reason is there are two hazards of bicarbonate therapy, and one of them is development of lactic acidosis. Lactic acidosis is a serious condition, so you would obviously not want, yeah, the treatment actually caused lactic acidosis. So how does that develop? I will need your attention, and this is slightly complicated concept, but I'm sure you will understand it if you follow. This is the oxygen dissociation curve, this one, right? And depending upon various physiological states, it could deviate toward right or left. Now, these are the factors which could shift that oxygen dissociation curve to the right, and these are the factors which can shift the oxygen dissociation curve to the left. Now, if this curve is shifted to the left, that would mean that oxygen delivery to the tissues will be reduced. Now, this is the normal position of the curve, and in diabetic ketoacidosis, there is reduced pH. We all know there is acidosis, so there is reduced pH, and that is trying to pull this oxygen dissociation curve to the right. But at the same time, there is deficiency of 2,3-DPG, and 2,3-DPG deficiency is pulling the curve to the left. So as a result, assuming both forces are equally strong, so the oxygen dissociation curve will remain in its normal position. That means oxygen delivery to the tissues will continue as per usual. But if we correct pH, if we raise pH by giving bicarb, this will then unopposed action of 2,3-DPG deficiency will pull the curve to the left like this, and oxygen delivery to the tissues will be reduced. Now, once oxygen delivery to the tissue is reduced, then of course there will be anaerobic metabolism, production of lactic acid, and lactic acidosis, and lactic acidosis is myocardial depressant, and lactic acidosis is big evil. So that is why routine bicarb therapy is not given. Routine bicarb therapy is only given when acidosis is severe, because we know that severe acidosis should be corrected, but once it is mild to moderate, then we should allow it to be corrected on its own. So I hope I was able to explain why bicarb therapy should not be given to those patients who have pH of 7 or above. The second is there is possibility of intracellular accumulation of acids. I'm not sure if I've used the right word. Acidosis actually means presence of acid in the blood or tissues, but I am actually referring to the accumulation of acid in the cells. How does that happen? Now imagine this situation. This is extracellular compartment and this is intracellular compartment. We are talking about a case of diabetic ketoacidosis. In diabetic ketoacidosis, we have already learned that carbon dioxide level is low and bicarb level is also low along with the pH. So these two things are low in extracellular compartment. Since extracellular compartment is in equilibrium with the intracellular compartment, intracellular carbon dioxide and bicarb will also be low. So intracellular, extracellular compartments are in equilibrium, and in both the compartments, carbon dioxide and bicarb are low. So carbon dioxide and bicarb ratio is actually important. If both are low, that is less harmful than one of them being low. What happens? Suppose we gave bicarb. So this is the bicarb. We infuse bicarb. It would obviously raise bicarb level. So this is understandable. Once extracellular bicarb level is raised, the pH will become less acidic and breathing will slow down and carbon dioxide level will also build up. So in the extracellular compartment, no problem. Bicarb has increased and carbon dioxide has increased, the ratio is maintained. But carbon dioxide is very diffusible. It will enter the cell immediately, whereas bicarb will take much longer to enter. So there will be a situation where carbon dioxide within the cells has increased and bicarb has not increased yet. Okay, so this is the situation where there is accumulation of acid, carbon dioxide being acid. It is not neutralized by bicarb because bicarb is not has yet entered. So bicarb deficiency and carbon dioxide is normalized. This is this suppresses muscle function. Now, if we're talking about the cardiac muscles, this could actually reduce cardiac contractility. Now, reduced cardiac contractility can further increase shock. So, this is a relatively complex mechanism, but they explain why routine bicarb therapy is not recommended. It is recommended only when there is severe acidosis. That means pH of 6.9 or less, and only sufficient to bring it to the safe level, which is 100 millimoles in 500 milliliter saline and infused over maybe 2-3 hours. Uh, this is a very important concept. I'm sure you know it, but let me explain that for in this context, flow sheet. A flow sheet means that you maintain the record in a systematic way so that you know which way things are going. So this flow sheet could be hourly, like this represent time, 9 o'clock, 10 o'clock, 11, just an example. And this is time. And then we have clinical flow sheet, you have laboratory flow sheet, you have therapeutic flow sheet. This means you have the monitoring of clinical signs and you note down here, and then laboratory abnormalities as you receive laboratory tests, enter them here, and therapeutic flow sheet, then you decide what is to be administered at what time. So all three can be on one paper or there could be three separate sheets. In clinical flow sheet, we measure blood pressure and we measure respiratory rate and we measure urinary output. Blood pressure, of course, patient is in a state of shock or hypotension. So if blood pressure is coming up nicely, we will feel very happy. Respiratory rate represent acidosis. So if respiratory rate is coming down satisfactorily, we'll feel happy. Then urine output, if patient is putting out urine in good quantity, that means he or she is getting good hydration also. So, and since this is just a clinical measurement, all we need to do is to a nurse or the house physician to measure these. Initially, we do it at least once every hour, but then of course, once condition improves, you can do it less frequently. Now, this is just a sample. You could, this is not that you have to do it every hourly here and every 2 hours here, but just to give you an idea that initially we do it more often and then we do it less often as the condition improves. And I think this flow sheet, just you go through the flow sheet, just one glance, and you can tell whether the condition is getting better or not. Then is the laboratory. We measure blood glucose. At that initially, of course, we measure at least once an hour and then less frequently. Once patient's glucose level is more satisfactory, we measure it maybe every 3-4 hours. And ketones, again, initially you can measure it maybe on alternate hours and then less frequently. pH again, initially first every 2 hours and then less frequently. And bicarb the same, depending upon the resources available. And once ketones have come less than 0.3 millimoles per liter, and once pH is 7.3, we officially say that the ketosis is resolved. Patient may still have deficiency of fluids, patient may still need some potassium and some treatment would continue, but the ketosis process, the diabetic ketoacidosis has resolved. Once pH has become 7.3 and once serum ketone levels have dropped to 0.3 millimoles per liter. This is marked as green. Then we have therapeutic flow sheet. That means we decide what to be given and what time. We give insulin, intravenous insulin infusion, regular insulin at 0.1 microgram per kg body weight can be given as a bolus and then the same dose per hour. But as I said, we can make simple 20 units bolus and 10 units hourly. And then once patient has recovered from ketosis and patient has started taking normal oral meals, then we must switch to subcutaneous multiple dose insulin regimens, twice a day, 3 times a day. Particularly if the patient this was the first presentation, then we have to send the patient home and we can't send him on insulin infusion. So in preparation of sending the patient home, we start subcutaneous insulin because you would need several days before you can adjust the dosage of subcutaneous insulin and then we send the patient home. Fluid initially normal saline, and once blood glucose level comes to 250 milligram per deciliter, then we add dextrose water and then we switch to oral feeding. Potassium chloride in the first 2-3 hours, potassium is not given unless patient had hypokalaemia to begin with. and then in the third drip onward we add 40 millimoles of potassium chloride in 1 liter and infuse it slowly, and then I think it is done till ketosis is resolved. Bicarb may not be given, but given if given only up to this point, if the pH is less than 6.9, and some other treatments. Now the patient may have some infection, sometime infection precipitates decay. So I think whatever else we can note down here, that patient needs antibiotic. So I hope you have understood the concept of flow sheet. Very, very important. If you want to stay organized and if you want the patient should get the right treatment, and you can just by looking at this flow sheet, you can have very good idea if the things are getting better or they are going in a wrong direction. Prognosis, there used to be 100% mortality before the invent of insulin. Insulin was invented in 1920, almost a century ago. So before the invent of insulin, before the discovery of insulin, in fact, there used to be 100% mortality. And there has been marked reduction due to use of insulin. It came down to 8%, but then we realized it's not just insulin deficiency, there is other problem also, like we understood this potassium deficiency better, we understood acidosis better, so further reduction due to better understanding of the disease. And currently the world figures are that the mortality of DKA should be less than 0.65% or at least 1%. And this is because of the application of new monitoring tools. We can measure glucose continuously, we can measure ketones as frequently as we wish. So, and I think that has led to better treatment. So I said diabetic ketoacidosis, if you treat properly, you should have mortality of less than 1%. In Pakistan, I guess it is still 3-4% because of the maybe poor handling or maybe because of concurrent complication. But we definitely need to work harder to bring the complication rate, the mortality rate to less than 1%, which is international figure. Recovery phase, once patient comes out of diabetic ketoacidosis, we have to educate the patient, particularly if the patient did not have diabetes before. So if it was the first presentation, then we need to sit down with the patient, explain to him what actually happened and what he needs to do. And particularly, we need to emphasize the fact that insulin would be needed for life. And we will have to explain the method of insulin injection and everything. Multi-dose insulin is given. Usually, I have it already covered in a separate lecture, but typically in type 1 we give basal bolus. If most patients with type 1 diabetes, they would require a short acting or rapid acting with every meal and one basal at night, and we have to make adjustment to bring his fasting and postprandial sugar to the normal level, and then ample carbohydrates for at least few days to replenish his potassium, this carbohydrate deficiency, and then address any complication. It is possible that some complication actually precipitated decay like pneumonia, and it is also possible that during the treatment, due to decay, patient develops some complication like deep vein thrombosis. So at the time of discharge, we need to thoroughly evaluate the patient and see if there is anything which needs attention. New trends in the management: low and weight-based insulin, fixed dose intravenous infusion of insulin, as against high dose which we used to use in the past. Venous blood gases instead of arterial blood gases. I'm sure arterial blood gases are still okay, but venous blood gases are easy on patient and also easy to perform. And as we are interested in pH, and the pH of venous blood is not much different than the arterial blood. So venous blood sampling should be adopted. Serum ketone instead of urinary ketones, because now we have serum ketone tests available and it is better. We should switch over from urine ketones to serum ketones. And ketosis prone type 2 diabetic patient can go back to oral anti-diabetic agents after recovery. Now, previously we used to think that anybody with the type 2 diabetes once go into ketoacidosis should stay on insulin for life. But now we have realized that some cases, due to some extreme situation, they can have DKA, even if they have some insulin, they have type 2 diabetes, they have some insulin in the body, but they went into DK because of the extreme situation. But once they recover, maybe very cautiously, you can try oral agents again if that is patient preference. Summary: in-depth understanding of pathophysiology of DK is needed to properly manage this condition. Treat hyperglycemia, dehydration, and ketosis according to the evidence-based guidelines, and I gave you some of the features of this. A properly maintained flow sheet is very helpful and to detect any treatment complication, and if you detect any problem, treat those complications. Mortality has reduced but still substantial. With help of newer monitoring methods, we should try to bring it down to less than 100%, which is the international figure. And DKA is one of the most well understood and most manageable condition. It is very resource demanding. It requires dedicated teamwork, but it is very heartening to know that most patients with diabetic ketoacidosis, which used to be fatal, 100% mortality, they can now be saved. With that, I'd like to thank you for watching this video, and this was on the treatment of DKA. And I would like to remind you that I have one more video in the series of acute metabolic complication, and that video will address relatively less common metabolic complications, that is hyperglycemic hyperosmolar state and also metabolic acidosis. So I will be really looking forward to see you there, and till that time, please look after yourself and join me in my next video. This was Professor Aziz-ur-Rehman from Medurstand. Thank you.